a beveled needle. This is the direction. This is the arrow. This is direction that the tip of the needle moves. And this is a beveled needle. This is a Medtronic needle. The tan is directional. The purple is bi-beveled, and the white is a pencil point or multifaceted needle. All right, so we're going to starting position. Let me clarify that. Starting position is here. Centimeter up, 2 centimeters out from the 2 o'clock position. And we're going to come down targeting 2 o'clock position. And it's going to be always not like this. It's going to be flatter with about the 3 o'clock position for implants that we'll also demonstrate later. All right, so tap, 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 coming down, and nice trajectory, good angulation. And before we violate the medial wall of the pedicle, we're going to look lateral, make sure that we're in the posterior portion of the vertebral body. And if we are, great, and if we're not, then we'll modify this a little bit. Okay, good. So just past the posterior border of the vertebral body. So we're going to go ahead and just, that's fine, you just leave it in. It's going to put it just past posterior wall. Let's drill. And we'll take a look and see where we are here. So very nice. Next step is to use the drill and drill it out to within 3 to 5 millimeters of the anterior cortex. You don't want to do more than that because you can come out the front of the vertebral body. If you want to, before you even do that, you can use a biopsy device. This is a cutting needle, and it has a lure lock on the end of it. You can aspirate for marrow and for bone. So you can just take a biopsy like this, like that. It's even picked up a nice core even after that drill. So you want to biopsy before the drill if that's what you're going to do. So next step, I won't do bilateral. I'm going to save the other side for another approach. But you put the balloon in, and the balloon has markers on it. This is a 20 millimeter balloon, and this is good for lumbar level, and that's about right. And so with the balloon inflation, you hit the on button so we know how much pressure is going into it. Start inflating it. You can see the pressure. You can also see the contrast coming into the balloon. And we see it coming up. Good. Let's take an AP shot of that and see how we're doing.
Hey, Dougie Fresh, they got
Yes.
me on the mic backing you up, so I'm going to throw in some comments every now and then.
Please do.
Dr. Beall was actually my staff when I was in the Air Force. We were both in the Air Force together, and so I was like 30 years old then. Doug was like 50 then. And somehow I got all the gray hair and he got none. But
That's right, but I can't grow any dreadlocks like you can, Easy. So we look pretty good. So this is going to be set up for a bilateral approach, right? So this is going ipsilateral. So this is a good transpedicular approach. That's 2.5 cc's. So I'm going to demonstrate, go to the other side, demonstrate the peripedicular approach. So on a line that goes from ipsilateral, inferior to contralateral superior vertebral corner, like that, our starting point will be vertebral body width, which would be roughly right there, right? So one vertebral body width out. Same as what I was demonstrating in the perpendicular approach in the lecture. So you come down from a perpendicular standpoint, wider throw, aiming with the same trajectory. All right. So that's good, I like that. And so what we're gonna do now is I'm gonna ask him to come 20 degrees toward me. Starting to feel os. It's probably the junction of the transverse process with the vertebral body at that point in time. So on here, we see we're anterior to the vertebral, to the pedicle, right? Just at or above the equator of the pedicle. So this is a perpendicular approach. This is why this is different. I'm going to tap it all the way down to the junction between the vertebral body and the pedicle junction. So this is right there. Okay. So let's take an AP shot. We'll just check our trajectory. And the en-face view, or the 20-degree oblique view, is only necessary if you kind of get lost, if you're not sure where you are. So we will go ahead and proceed. And we'll come down, going into the vertebral body. And we'll hammer through the frozen. All right, so it's important here to never transgress the medial wall of the pedicle before we're in the posterior portion of the vertebral body. So I'm going to come down here, and I'm going to get right at the medial wall, and this is a beveled needle. So if you need a few more millimeters, and we look like, if we look here on the lateral view, we're not quite in the posterior portion of the vertebral body. What we can do is we can come back to the AP view, turn the needle 180 degrees, and use the bevel to your advantage. So it kicks it lateral. So with this, we'll just take a look lateral. There, we shouldn't be at or near the posterior portion of the vertebral body. And this is a wider throw, so it puts the needle tip more medial than a transmedicular approach. There we go. So, okay, better. So one of the things you can do to get more medial is to back that needle up, right? Not that far. Right there along the posterior portion, and you can use the anatomy of the needle and also a little English to get it more toward the center of the vertebral body. So, kind of almost in the middle there. And we can tell by the external trajectory of the needle that it should be at or close to the center of the vertebral body on the AP view. And so this is a way to quickly access the center of the vertebral body.
Now, Doug, here, as you really stressed the fact that you were going for the center of the vertebral body. Suppose you were to look at an MR and you saw that the predominant component of the fracture and that inversion recovery sequence favored one end plate over the other. Would your approach be any different?
So what we really have to do is target the fracture. And I've seen a paper by Lynn said that clefts of the fracture have to be filled. If they don't, it's not going to be optimal for pain relief. So we use the anatomy of the fracture to make sure we really have that thing filled. And if you're worried about filling the cleft, target that spot. So if I knew there were a cleft in this one, I would start filling here, because the most important thing is you fill the cancellous bone in addition to the cleft, not just the cleft itself. So I would start filling here, knowing that I have to get cement to the superior portion of the vertebral body. Let's look lateral.
Yes, sir.
And sometimes that doesn't fill. You have to really know the anatomy of the vertebral body. Otherwise, people call it a treatment failure. And it's really not a treatment failure, it's a knowledge failure. Failure to recognize the fracture cleft and failure to get it in the appropriate spot. So this is angling more toward the inferior portion of the vertebral body. If we really want to change trajectories, we can just angle it up. And this is why I like the beveled needle, because it allows you a lot of leeway. whoops, get my arm out of the way. So you can come more toward the superior portion of the vertebral body, far away from where we were previously. And if we want to go back along the posterior wall, posterior margin, which we can do without providing any damage because we're outside the neural structures. So I'm right along the posterior margin of the vertebral body, right there. I can really get some trajectory changes to be able to access that superior portion of the vertebral body. So just know the anatomy of the fracture, know the anatomy of your needle, and use this to your advantage. This is a good tip and trick that you can use to get to wherever you want to go in the vertebral body. Okay, let's try the inferior in-plate extrapedicular approach. So we'll go about 45 degrees angled towards you.
Okay, Doug, so for some of the people who may just be starting, you get your needle in like this and you get ready to fill the cement. You pull the interstylet out and you just get that big blast of blood back. I know you've seen that before. Anything that you do differently there?
No, just put your finger over it so they don't bleed to death while you're doing the augmentation procedure. People bone bleeds, and sometimes it bleeds very briskly, and some people bleed a lot more intraosseous wise than others. So number one, don't panic. Know that bone bleeds. Number two, just put cement in early so you can, before you blow the balloon up, if you're having trouble with bleeding, put a little cement in there. It will tamponade the bleeding, and it will, there's nothing wrong with blowing the balloon up amidst the cement, especially with the low compliance balloons. They're relatively cement resistant. So just kind of be aware of that you will see that. That's a good point, Easy. You will see that. You know, people sometimes freak out whenever they have.
Yeah, it's an exercise in sphincter control.
There we go. Exactly. Okay, so 45 degrees. We're going to go just above the end plate, just anterior to the pedicle. And this is the modified inferior end plate extrapedicular approach. So just anterior to the pedicle, just above the end plate, and that's a good start point. And I can feel already the os is pretty soft, as it tends to be in that location, especially in osteoporotic patients. So don't go too far posteriorly or to the left. Don't go up to the middle because of the nerves and the sigmoid artery, respectively. And let's take an AP shot from there. And you can see the trajectory on this is very flat. All right, so it's a different type of look, isn't it? Just above the inferior plate, and we'll transgress here. And we'll put the needle tip kind of toward the center of the vertebral body. Let's take a look lateral and see where we are. And I want to call your attention while we're doing this. This is the OsteoCool system from Medtronic. This is a chicken breast, and we're doing OsteoCool with ablation. We're doing smaller ablations rather than larger ablations here, but you can ablate the entirety of the vertebral body. So this is something that I use for every single tumor case for radiofrequency ablation prior to doing the augmentation. Some people feel you can do augmentation alone is acceptable. That's probably okay, but I believe that there's reported cases by Cruz that purports to report, and I believe it, spread of tumor after balloon kyphoplasty. There's a good paper by Kieran Murphy that shows that you can actually induce active tumor cells intravascularly after you do a balloon kyphoplasty if you don't ablate before. So this is an important technique to keep in mind. Always ablate prior to doing the vertebral augmentation. And so this is the lateral view, and we're about halfway across. So we want to be at kind of the mid to anterior portion of the vertebral body on the lateral view, and kind of in the mid portion on the AP view. So that should suffice there. Let's flip it around to AP and see where we are. Very good. So almost there in the AP view. Okay. Final needle tip position. Very good. Modified inferior plate, extrapedicular view. And why don't we go ahead and inflate a balloon and put some cement in here. We'll demonstrate the CDS, cement delivery system from Medtronic. And we probably have speed, don't we, as the cement? So put the balloon here. I'm going to advance it just a little bit with the drill. It's not quite osteoporotic enough just to stick the balloon out on its own. Okay. All right. Balloon goes out, maybe. Okay, one more time. All right.
Not yet.
Okay. Balloon's out. We'll inflate it. Let's go lateral. Yeah, so that's a good question, Neil. So the optimal amount of cement that you put in the vertebral body is probably more than you think. We want to end-plate to end-plate between the pedicle fill, and on the average, you want to fill between 15 and 25% of the non-compressed level. So on a lumbar level, that will be 6 to 8 cc's, and at a thoracic level, it will be 4 to 5 cc's. And usually, people don't like to fill that much because they're not quite sanguine with the anatomy. But what we like to do is fill all the way to the posterior wall. People say you're not, a meme that's been repeated over and over again that just isn't true is that you're supposed to stay away from filling all the way to the posterior wall, which is just simply not true, because the greatest amount of stress and strain after you recreate and reconstruct the anterior column, the vertebral body, will be on the posterior portion of that vertebral body, which is going to be on the middle column, if you're referencing the columns of Denis. So need to fill it up all the way to the posterior portion, and people typically don't do that because they're afraid of extravasation. But if you have a lot of extravasation that's enough to be symptomatic, there's one of two things you're doing. You're either not paying attention or you're not recognizing important extravasation, neither of which is optimal. So just kind of modify your technique. And this is a cement delivery system with the trigger, and it delivers the cement hydraulically. This is speed, which is a quick to dose cement, and this is the quick off. So if you see it extravasating or cement misbehaving, you just hit that and it'll stop the whole system, and you have to kind of power it back up. And so we're going to use the entire volume of X-speed on this one. Yep.
Doug, also comment about what you consider significant extravasation.
Well, so the only extravasation that's going to be significant is if it goes into the spinal canal a lot or the neural foramina. So we talk about symptomatic extravasation or just extravasation. There'll be, the registry had extravasation in almost 25% of the cases, none of which were significant. And that plays out over and over again. Vertebroplasty, some vertebroplasty articles, you'll have extravasation in 70% of the cases. if you look at it with CT. So I think extravasation means nothing. I mean, extravasation to the lungs, for example, you don't want to exceed the maximum allowable, just for somebody to be hurt by it, to get a symptomatic pulmonary embolism. I think that should be okay. But if you measure it, you get between 5 and 25% of the time you get extravasation that goes to the lungs. So it's just a matter of not getting too much, not getting into the critical areas. But extravasation per se is anything that happens 1 in 4 times is a normal occurrence. So this is probably going to be about almost 16 cc's of cement if I pump the whole thing in. All right, let's take a look, AP, see how we're coming. So it looks very nice. Nice central fill, almost end plate to end plate. All right, let's flip it back lateral when we finish filling. And we've got the ablation patterns here in the chicken breast that we can see very nicely. And this is all automated. This is done with cool radiofrequency. And this is effective at ablating the whole tumor. You can ablate the whole vertebral body with this. Drop it down a little bit, yeah. All right. Oh, yeah. So that's roughly about 16 cc's of cement, right? It's a lot of cement. I cannot say that that is unusual, though. A lot of my cases will take 10 cc's or more. All right. Any questions on the approaches, radiofrequency ablation, cement, or anything else?
You kind of clearly define when you use the inferior end plate. Vertebral plana is one where I use it most frequently, but instrumentation as well. Do you have any preferences for when you use para?
I kind of use para almost every time. It's fast, you don't break the pedicle off, it's easy to get in there. So I use perpendicular as kind of my fastball. The transpedicular approach is, to me, the difference between para and trans is kind of arbitrary. One is farther out, one is closer in. So I don't even really look at too much at the landmarks except the medial border. And I know if I'm going farther out, it will be functionally a perpendicular approach anyway. So that's kind of how I do it. And I don't really define the difference between trans and para. If I want to go transpedicular, I start further in. If I want to go perpendicular, I start farther out. Just kind of that simple.
Can you use all 3 approaches with slack?
And it really doesn't matter. You can go on FOSS. Just show me about a 30-degree oblique, ipsilateral towards you.
Hey, Doug, we had a question that said, can you use the different approaches for spine jack? That's out of my wheelhouse.
Spine jack is only transpedicular. Yeah. And in the thoracic spine, functionally, it's a perpendicular approach. But yeah, I mean, you have to, the approach for spine jack, we'll show that later today. Let's see. You take that off, Mag. Okay, so the other one is the on-FOSS view. And this is right down the barrel of the pedicle. So this is a 4th approach. Some people like to do this one, just kind of right down the barrel of the pedicle, not to violate the medial border. All right, let's flip it back AP. Okay. There we go. And go back to that 30-degree oblique view. And you should see that right. We start up the edge of the pedicle. We should see this right down toward the center of the pedicle. And actually, that's a periapedicular approach. Let me get a little bit farther medial. So there we go. So it's right middle of the pedicle. And we'll just look down the barrel of the pedicle until we get there. Okay, let's go ahead and take a lateral. We should find that we're in the posterior portion of the vertebral body. So some people like to do this, minding never to violate the medial wall of the pedicle until you're in the posterior portion of the vertebral body, like that. And that's a beyond pos view, or the bullseye view. That's another optimal technique that you can use. So there's really 4 different techniques of approach. Questions, comments? Thank you. All right, guys. Thank you very much.